So thank you for inviting me to speaking about this subject. I'm very glad to be here. We are going to talk about imaging ovaries in adults and how do we do in routine. So first of all, why is it important to correctly characterize an adnexal tumor? Because as you all know, masses which fail to be benign don't necessarily need oncological surgery and can be managed expectantly or with minimal access surgery. Whereas for suspected malignant or borderline tumors, there is a loss of chance if they are not referred to a trained center specialized in oncological surgery. Third thing, which is becoming better known, is the fertility impact of ovarian surgery in women of reproductive age, so we must avoid, when possible, unnecessary surgeries. What do we have to correctly characterize an adnexal tumor? We have CA125, which is not specific as it can be raised in benign pathology and in only 50% of ovarian cancer. Then we have ultrasound, which is the most commonly employed and best primary imaging modality, and we have MRI. We are going to detail these two techniques. How can we improve our practice? First, we have to always do transvaginal ultrasonography when possible. Transabdominal ultrasound must be reserved for virgin patients, large masses, or for the analysis of the urinary tract. Then appropriate settings include the use of harmonic imaging, which is better to define the outline of the cysts, and power Doppler imaging that is better than color Doppler imaging to detect slow flows. Then we have to use our free hand to gently push the transducer towards the structure we want to analyze, looking for a deformation that makes the diagnosis of a peritoneal pseudocyst, or for internal movements as seen in hemorrhagic cysts. Then we can make the diagnosis of extra-ovarian tumors when we can separate the cyst from the ipsilateral ovary, and finally to move closer ovaries or large masses. Then, and this is the most important thing to record, we have to speak a common language by using the terms and definitions and measurements of the International Ovarian Tumor Analysis Group, which has described simple ultrasound-based rule for the diagnosis of ovarian cancer. What are these terms and definitions? First, a septum is defined as a thin strand of tissue running across the cyst cavity from one side to another. It can be complete or incomplete. Then a solid papillary projection is defined as any solid projection developed from the cyst wall into the cyst cavity with a height greater than or equal to 3 millimeters. The number of the papillary structures should be recorded as below: 1, 2, 3, or more than 3. Then a solid portion is defined as a portion showing high echogenicity greater than the myometrium and with blood flow. Then we have to describe the dominant feature of the cystic contents. It can be anechoic, that it means all black, or low-level echogenic, as seen in mucinous tumors. It can have a ground glass appearance, as seen in endometriomas. It can be hemorrhagic or mixed echogenic. We also have to describe the associated signs, which include acoustic shadow, defined as a loss of signal behind the tumor, or a cyst that has to be looked for in the pouch of Douglas in a sagittal plane. That was for the morphological features. Then we have to describe the vascular features, recorded as below: no blood flow, minimal blood flow, moderate blood flow, or high blood flow. Be careful when you have no blood flow. It doesn't mean that the tumor is not vascularized, because the signal can be negative when the tumor is poorly vascularized. So it simplifies the analysis of adnexal tumors, as the IOTA group has described 6 categories of adnexal tumors. You can have a unilocular cyst with or without solid components, a multilocular cyst with or without solid components, an entirely solid cyst, or the last category is the not classifiable tumors. We are going to detail all of them. First category, the unilocular cyst, is defined as a cyst with no septa, no solid part, and no papillary structure. Its echogenicity can be pure or impure. When the cyst is pure and ovarian, you have 2 diagnoses. It can be a follicular cyst in women of reproductive age when the height is greater than 3 centimeters, or a benign serocystadenoma. Diagnosis will be made in postmenopausal women when the height is greater than 1 centimeter, and in women of reproductive age when it remains beyond 3 months. Then, when the cyst is pure and extra-ovarian, you have 2 diagnoses. Peritoneal pseudocyst the diagnosis of peritoneal pseudocyst will be made by deformation over palpation, and of para-ovarian cyst when you can separate the cyst from the ovary. Then, when the cyst is impure, you have 3 possibilities. Most common is the hemorrhagic cyst, which has typically a height greater than 3 centimeters, a fishnet appearance due to the fibrin cells, and internal movements over palpation called the jelly sign. It has also peripheral circumferential blood flow. Second possibility, an endometrioma, which has typically a ground-glass appearance and no or low peripheral blood flow. And third possibility, the dermoid cyst, which is typically mixed echogenic with an important acoustic shadow. Second category, the unilocular-solid cyst, which is defined as a cyst with at least 1 papillary structure, which height is greater than or equal to 3 millimeters, or a real solid part occupying less than 80% of the tumor. Unilocular solid cysts include hydrosalpinx, which is easy to recognize due to its typical tubular aspect. Then you can have a cyst with a papillary structure, which defines the epithelial tumors. When you have one, MRI is necessary for characterization, as you can see papillary structures in benign tumors and in borderline ones. Then you can have a cyst with a solid component, and in this situation too, you have to perform an MRI to correctly characterize your tumor, as there is a wide variety of diagnoses from benign tumors to malignant ones. Third category, the multilocular cyst, defined as a cyst with at least 1 septum and no measurable solid components or papillary structures. Most common is the benign mucinous cystadenoma, which is typically large, multilocular, with locules of different echogenicity. You can also have a benign serocystadenoma, which has less locules than the mucinous type, maximum 4, and of same echogenicity. In both situations, you have to perform an MRI to look for a borderline component, especially in mucinous cysts. Fourth category, the multilocular-solid cyst, which is defined as a cyst with at least 1 symptom with a measurable solid component or a papillary structure. In this situation too, you have to perform an MRI to correctly characterize the tumor, as there is a wide variety of diagnoses from benign tumors to malignant ones. Fifth category, the solid tumor, defined as a tumor with a solid portion or papillary structures occupying 80% or more of the tumor. In ultrasound, there are some signs that you have to look for that can help you making the diagnosis. If you have an acoustic shadow, then there is 4 diagnoses. It can be a leiomyoma, it can be a dermoid cyst, a textiloma, or an ovarian fibroma. When you have signs of hyperestrogenic state, like an endometrial thickening or adenomyosis, then you can make the diagnosis of a granulosa cell tumor. And if it's bilateral, most common is lymphoma or metastasis. In each case, it can be difficult to make the diagnosis in ultrasound, so you have to complete your exam by MRI. Sixth category, the not classifiable tumors. When you can't see properly in your ultrasound, you have to perform an MRI. So, to resume, when do I have to perform an MRI? It's simple. When you have a unilocular cyst, either it's pure or impure, it means that you have no solid portion, so that the tumor is benign, and you just have to do an MRI when the height is greater than 7 centimeters. When you have a multilocular cyst, a papillary structure, or a solid component, then your tumor can be benign, borderline, or malignant, so you have to complete your exam by making systematically an MRI. We also have to improve our MRI techniques, and basic MRI examination include T2 weighted sequences, T1 weighted sequences with and without fat suppression, diffusion weighted imaging, and dynamic contrast enhanced sequences, which will give you the time intensity curves. When you analyze your MRI, you have to follow these 3 steps that can direct you to some diagnosis. First is the tumor I see ovarian. Then, second question, is there a risk of malignancy? And to answer this question, you have to answer the 3 following questions, which are: first, do I have an internal enhancement? And if I have one, is it a real solid portion? And if I have a real solid portion, then does it show malignant criteria? And finally, can I make an histological diagnosis? First step is the tumor ovarian. You have to look at the T2 weighted sequences and locate the ipsilateral ovary by looking for the follicles, which are typically in high T2 signal. When you can see normal adjacent ovarian tissue, then it's an important sign because the tumor you see is highly likely to be benign. When the ovary is not thin or atrophic, like in postmenopausal women, then you have to follow the ovarian pedicule. On the left side, it arises from the left renal vein, and on the right side, from the inferior vena cava, as you all know. There is a third sign that can help you, it's to locate the ipsilateral ureter, because ovarian tumors move ureter backward and laterally. Then, second step, do I have a risk of malignancy? And first thing, do I have an internal enhancement? When you have no internal enhancement, then you can be relieved because the risk of malignancy is less than 5%. Smooth and thin septa, less than 3 millimeters, aren't malignant, even if they show enhancement after injection. When you have no internal enhancement, there are 4 entities which we know, and we are able to state the benign character as their risk of malignancy is close to 0. These 4 entities are a purely cystic mass, a purely endometriotic mass, a purely fatty mass, or a mass without wall enhancement. For the purely endometriotic mass and the purely fatty mass, you have to look at your T1 weighted sequences, looking for a high T1 signal intensity. When you have one, you have to look at your fat suppressed T1 weighted sequences. If the signal remains bright, then you can easily make the diagnosis of an endometrioma. And if it becomes dark, then you can make the diagnosis of a dermoid cyst. When you have an internal enhancement, the question you have to answer is it a real solid portion? And the term solid tissue only includes these 3 features: papillary structures, irregular thickened septa, and solid portions. When you have one, you have to first characterize its signal in the T2-weighted sequences and in diffusion. When you have a dark signal intensity in the T2-weighted sequences, then your tumor is highly likely to be benign, as it's probably fibrous. When you have an intermediate T2 signal intensity, then it's not informative, as it can be seen in benign tumors, borderline tumors, or malignant ones. In diffusion, it's the same thing. When you have no high signal in diffusion, then you can state that your tumor is benign. When you have a high signal, it's not informative, as it can be seen in benign tumors, borderline ones, and malignant ones. ADC measurement is not informative, even if we know that malignant tumors show low ADC. Then, do I have a malignant criteria? And for this, you have to look at your time intensity curves obtained with the dynamic contrast seance sequences. 3 types of curves have been described using the adjacent myometrium as the reference, and which are correlated to the histological type. First curve, type 1, the benign one, describes a gradual enhancement. Second curve, type 2, which is found in borderline tumors, describes an enhancement earlier than type 1, but which is also later than that of the myometrium, with a plateau effect. And type 3 curve, which is specific to invasive malignant tumors, describes a curve that is shifted to earlier than that of the myometrium. So, final step, with all these features, can I make a diagnosis? Yes, if I am in this situation when I have a low T2-weighted signal, no high signal in diffusion, and a type 1 curve, then I can state that the tumor is highly likely to be benign. In this situation too, when you have a type 3 curve specific to invasive malignant tumors, then you can state that the tumor is highly likely to be malignant. When you are in this situation, when your T2 signal intensity is intermediate, when you have a high signal in diffusion and a type 2 curve, then it's not informative, and you have to look for associated signs that can direct you to some diagnosis. If you have peritoneal implants, then you can say that the tumor is highly likely to be malignant. When you have lymphadenopathy, you can say that the tumor is highly likely to be malignant or borderline. And when you have signs of hyperestrogenic state, that can direct you to the diagnosis of a granulosa cell tumor. To finish, just 2 little examples. In this image, you can see that you have a unilocular-solid cyst. You can see papillary structures, and after injection, their T2 signal intensity is intermediate, and you have a high signal in diffusion. When you analyze your curve, you can see that it's a type 2 curve, similar to the curve of the myometrium, with a plateau effect. So all these features can direct you to a borderline tumor confirmed at surgery. Last example, you can see a multilocular-solid cyst showing solid portions, irregular secant septa, papillary structures, and ends after injection. Their signal intensity in the T2-weighted sequence is intermediate, and they show high signal in diffusion. When you analyze your curve, you can see that it's shifted to earlier than that of the myometrium, which defines the type 3 curve specific to invasive malignant tumors, and that was confirmed at surgery. So to sum up, what are the main messages to record? First, we have to optimize our techniques and use appropriate settings. Then, and this is the most important, we have to speak a common language by using the terms and definitions and simple ultrasound-based rules of the IOTA group. And then we should follow these three steps analysis in MRI that can help us making the diagnosis. Thank you.